Welcome to our Faculty Academic Staff Forum Series at UW-Eau Claire. My name is Melissa Wallace. I'm the Research Compliance Specialist in the Office of Research and Sponsored Programs, and I'm delighted to introduce today's speaker. Dr. Abby Hemmerich is a professor in the Department of Communication Sciences and Disorders. She teaches in the area of voice disorders and medical speech language pathology for both graduate and undergraduate students. Her current research is focused on interprofessional learning experiences for graduate students. The title of her talk today is Inter-University Interprofessional Education, Implications for Faculty and Students. And before I turn things over to Dr. Hemmerich, I'd like to note that we will have time afterwards for questions and comments from the audience. For our remote viewers, if you have any questions, please submit them in the Q&A either at the top or the bottom of your screen, and our wonderful graduate assistant, Matt, will read them aloud. And Dr. Hemmerich, if we do have questions from the audience, if you could repeat them for our online viewers.
Okay.
With that, I will turn it over.
All right. Yay. Okay, well, thank you very much. I'm excited to talk about a project that's been kind of near and dear for a couple of years now, thinking about interprofessional education, which is a really important component for our students. So I want to start, though, with our land recognition statement. We acknowledge that the University of Wisconsin-Eau Claire occupies the sacred and ancestral lands of Indigenous peoples. We honor the land of the Ojibwa and Dakota nations. Okay. And before I kick off actually talking about some of the research, I need to start by thanking all the people that have made it happen. So I got interested in interprofessional education back in 2021-ish, kind of around COVID time, maybe a little before 2021, when Bailey Harder was a graduate student in our department, and she had an interest in this area and pursued a thesis in this topic area. So she actually is the one who got the ball rolling with all of this. She contacted Laura Schaefer and Inga Kluppert, who are down at UW-La Crosse. Laura is an occupational therapy professor down there, and Inga is in the physical therapy program down there. And Bailey just reached out, cold called them, and asked if they would be willing to collaborate. And they said, hey, we have an experience already set up. Come on in and participate with us, and everything else is just history since then. So huge thank you to Bailey for getting that going. Since then, I have had multiple undergraduate student research teams looking at this experience and measuring different aspects of it. So that's what I'm going to talk with you about today, but really wanted to give a shout out to them at the front end for all the work that they've done. So Hannah and Brooke have long since graduated and are in graduate school now. Kelly and Annika also in graduate school, but just finished up a project last year. And I have two students this year who are focusing in a little different way on IPE, but still continuing to look at that. I also, even though the bulk of this talk will be about my collaboration with UW-La Crosse, I want to mention another collaboration that we have with CVTC and the respiratory therapy program there. So I'll just talk a little bit about that today and working with Kirsten Holbrook, who is a respiratory therapy instructor over there. All right, so here are the main things that I want to make sure we talk about today. First, just a definition of IPE, if folks are unfamiliar with that, and then talk about clinical simulation, and I'll get into that a little more in a second. I'll give you some examples of the IPE experiences that we've been doing in speech-language pathology. This is probably a good point to just mention. Our department is Communication Sciences and Disorders. We prepare undergraduate students for a variety of pathways. Speech-language pathology in the graduate program is one of those pathways. So the research that I'm talking about is with our graduate students, but broadly in our field, this applies for our undergraduate students too. And then I'm going to talk a little bit about students and their perspectives and their learning, and then a little bit about faculty perspectives at the end as well. So let's start with what IPE is, interprofessional education. And this is an opportunity for students to learn, work, and gain skills together to facilitate successful collaboration with various professions. So when we think about IPE, we should think about students learning together in some way. There's lots of ways that that can look. It could be as simple as having them in the same classroom and just having a conversation, all the way to actual clinical practice, working side by side with real patients, and anything that you can imagine in between. There are many, many benefits of IPE. I've listed some of the big ones here, just things that we really look for our students to learn as they're going through this experience. The big one, learning to work with other professionals, really promotes patient-centered care. So for folks who are not aware, speech-language pathology has a healthcare component. We work in hospitals, we work in nursing homes, outpatient clinics, in some pretty heavy-duty medical kinds of needs. The picture here is a patient with a tracheostomy, so a tube for breathing, and our role is to help with a speaking valve to allow them to communicate and swallow when they're wearing that. So patient-centered care is a big piece of that, and IPE helps foster that. Obviously, it gives them a chance to learn about team building, how to work together with other disciplines. Lots and lots of opportunities to develop their communication skills. So as they're talking to my students, physical therapy students, they need to learn the terminology to use with one another to understand each other. So some good opportunities there. They start to develop some leadership skills as well. Who should step up and take the lead in a particular team or situation? Improving their understanding of the workplace culture and the workplace environment that they might be thinking about. So it's really easy for me to talk about that in the classroom, but to get a real feel for that, they need to start interacting with other professionals. One of the big takeaways that I've seen personally, I'll talk more about, is their understanding of the roles of other disciplines and other professionals, and then just improving their confidence and their ability to collaborate with people who have different perspectives than them. So lots of published benefits out there, and we'll come back to some of these as we see what our outcomes have been in this program. So now I want to talk about simulation, because as I mentioned, IPE can show up in many different ways. And some of them are more didactic, but we've really leaned towards simulation opportunities. So in this context, the term clinical simulation, as I'm using it, could be broadly defined as the use of tools or devices or an environment to mimic a particular aspect of clinical care. So I'm going to talk about two different, the CBTC experience and the UW-La Crosse experience, where we're using different kinds of simulation, but simulation nonetheless. And IPE through simulation really promotes implicit learning, and we'll come back to this idea too, about the structure and the types of interactions that they might have in clinical settings, and gives our students perspectives on how to do collaborative work in realistic settings. So not just something contrived in the classroom that we've come up with. Sometimes that's the next best thing, but these simulations are really helpful. So some of the benefits specific to simulation, you can see up here. It's a pretty controlled environment. So whether it's a student role playing the patient, or in like the case of CBTC, we use a mannequin. You can't kill your patient, which is very helpful for students who are just learning. I know that sounds extreme, but some of the things that I'm teaching right now with my graduate students, if they do this wrong, it could have a very negative outcome. So being in these safe environments to practice those skills, make the mistakes, and not have a negative patient outcome is important. Gives them an opportunity to build confidence with different kinds of clinical populations. It's not always easy for us to access certain types of patients for our students, so it's really helpful to have that. Also, the similarity that we can present to our students. So we can see all of our students interact with the exact same kind of patient. If we want to do assessment, I have not done that as an assessment, but you could use that as an assessment tool to see how they're doing in their learning and understanding of that clinical situation. Specific to our field, we have some very rare populations that it's hard to get our hands on. So our students, towards the end of their program, the graduate students, do a placement out in the community. Educational settings, we tend to have pretty good access. We can get them into schools to do that. Medical settings are more challenging, as you might imagine, just the nature of our region right now in general. But medical settings post-COVID have just really clamped down on things. So we can't always get all of our students into a hospital kind of placement. So sometimes the simulation is the next best thing. And then the last piece up here, repeatability. So having a chance to see a patient or role play a patient, think about it, reflect on it, and go back and repeat that gives students an opportunity to really dig deeper and learn a little bit more than if it's just a one-off opportunity. Before I keep going, I'll just pause. Anything audience-wise first? Yeah, so the question is, can you call classroom teaching IPE if it doesn't include hands-on component? You can, as long as there's more than one discipline in the classroom. So there are examples out there in the literature specific to our field where folks who are just, they're in the classroom learning together. So for example, social work students, CSD students, maybe at other universities, physical therapy, occupational therapy, and they're in an ethics course together. So that would be considered an IPE experience, but it's a different kind. So, I'm kind of focused on the hands-on type with what we've been doing. Yeah. All right, so let me talk a little bit about what those experiences look like. So in our partnership with UW-La Crosse, we are representing the speech language pathology component of the field in healthcare settings, particularly rehabilitation settings. So folks who are post-stroke, post-brain injury are likely to see our discipline, as well as occupational therapy and physical therapy. We don't have those two disciplines on our campus, so thus the birth of this inter-university collaboration that we've needed to do. So in that partnership with UW-La Crosse, we have the students play the role of the patient, so I'll talk about that in just a minute. We do go down to UW-La Crosse for that event, so that's one of the challenges of inter-university collaboration. Somebody has to travel in one way, shape, or form. The first time that we did it was still in COVID restrictions, so we actually went virtually, did a Zoom session. It was less effective than us going in person, and eventually we'll kind of figure out that telepractice piece, but finding a way for us to get all in the same space is important. In that La Crosse partnership, students work in groups of 4 to 6. As I said, one student plays the patient role, but we need at least one individual from each discipline to be in the clinical role as well. When we go over to CVTC, we just did this a couple weeks ago. One of my favorite things to see our students do. Over there, it is just us and respiratory therapy. So CVTC provides the respiratory therapy students, and we bring the speech pathology students. And we go over there to use their high fidelity simulation lab. We have that here too with nursing, but we really need the respiratory therapist to be a part of this interaction. So they have a simulated mannequin patient that has a tracheostomy. So as I said, that's a breathing tube through the neck if you've ever seen a patient that has one of those. And when we go over there, the respiratory therapy students are really teaching our students how do they manage the breathing and the airway and taking care of that component of the patient care. And our students are there to help with the communication and swallowing piece of that. So just wanted to kind of give an overview of what that looks like. We do have in CSD some on-campus IPE that's happening as well. And I just wanted to mention those because it's not all just inter-university. So a colleague in CSD has established some simulations with nursing, looking at also stroke patients, but how does an SLP interact with the nursing staff for those patients? And then we have a clinic on campus. If people were not aware, the Human Development Center actually sees real patients. So we're not talking IPE anymore. Now we're talking about interprofessional practice, IPP. And students from our program, school psychology, some other disciplines come together and serve real patients in that clinic. So lots of different ways that that's happening on our campus too. So for both of the events that I'm talking about today, the student learning objectives are to learn about other disciplines. What are their roles? What are their responsibilities? And then identify areas where they may overlap in terms of what they do with patients. The two experiences that we're talking about today tend to be assessment oriented or evaluation. So how do we go in and figure out what's wrong with the patient and how we can help that patient? We could certainly build some eventually that are more therapy oriented too, which is the other part of what we do. At UW-La Crosse, it's also a little bit focused on the rehabilitation case, specifically post-stroke care for a patient like that. And CVTC then more specifically about that tracheostomy or airway control kind of situation. Okay, this is probably the last part that I'll share about CVTC because we haven't done really any specific research on it, but just it's kind of a growing part of what we're doing. So at that experience, you can see in the images up here what that looks like. This is their simulation lab space. So all of the students in green, so these kinds of outfits are the respiratory therapy students, and then ours are more traditionally just whatever they came to school in that day is what they're wearing. So during this experience, they get some information before the event. We tell them a little bit about what the case is so they kind of know what to expect. I tend to do a little bit of preparatory work with my students because they've never been in a hospital room before as a speech language pathologist. So I do a little bit of front end warning about smells and sounds and just what the experience is going to feel like. But I can't recreate what they experience when they actually walk in the room. So it's just so powerful for them to be there. On the day of the event, they get a brief orientation to the simulation lab. They get a list of some talking points and then some assessment tools. So for respiratory therapy, they need some suctioning equipment. That's what they do in the real world, suction patients and do all kinds of respiratory treatments. The speaking valve that we need is there. And what it looks like is about 25 minutes in the lab, in the sim lab, in a group like this, where they actually interact with the mannequin that you can kind of see on the end there over here. where the respiratory students do their steps, our students do the speaking valve placement, and have about 25 minutes to work through that. They also have about 45 minutes outside of the sim lab where they can just have a conversation between the disciplines. Lots of learning happens there. They can ask each other questions. Why did you do this particular thing in this particular way? So I think, you know, the learning in the simulation lab is important, but the discussion that happens outside of that is also really, really important to help them understand how other disciplines would interact. So at UW-La Crosse, when we go down there, also kind of a interdisciplinary co-evaluation, but now a stroke patient, post-stroke kind of patient. And this process is a little bit longer. So we go there, that's about a 2.5 hour experience as opposed to the shorter with CVTC. So before the event, they get some information about their patient. For those that are sort of unfamiliar, we usually are talking about a left CVA, a stroke that's a cerebrovascular accident, causes aphasia, which is difficulty with language. So cognition is still intact, but difficulty with getting their thoughts out in a clear manner. And then they have right-sided weakness. So you can see how PT and OT and speech all sort of fit together in that kind of case. They also get some notes, medical kind of documentation that they would expect to see in a traditional hospital kind of setting. And all of the students do the NIH stroke scale certification. So they all have a chance to kind of have a level playing field, just some basic knowledge. I think they all are far past that in terms of what they learned in their classes, but just so they all kind of have the same terminology as they get started. On the day of the event, when they show up, you can see kind of what that first looks like. So they come in and work with their team. They get some information, a planning guide. They get some patient instructions. So whoever's going to be the patient, you can see this guy's prepping over here to be the patient for his group. The tools that they need to do their assessment, and then we just give them time. That's really what they need, is time together. So they spend 20 to 30 minutes kind of talking to each other, learning about the other disciplines that they're going to be working with. They plan their evaluation. So they have a 30-minute evaluation that they need to complete together. And if you look at their planning guide, it's 2 pages long of things that they should be assessing. So they have to figure out how they're going to get through all of that in that short period of time. They have a chance then to actually do it. So the patient, role play patient, follows along with whatever they ask them to do. And then after that, they have a chance to debrief and fix what didn't work and try again. So I will say this again later, but just to highlight, this is not about the evaluation. We don't care if they get through the whole thing. Most of them don't get anywhere near finished with it. It's really about how they communicate with each other and what they are learning from each other as they go along. Really, the biggest thing is that learning through doing piece. And I'm going to talk about some of the data that we've collected here in just a second. But as they go to implement that plan, this is kind of what it looks like, right? So sometimes it's conversations between the disciplines. Sometimes it's talking with the role play patient, trying to actually implement what they would do in a clinical setting, right? You see some physical therapy students moving patients. And the big learning happens when they have a plan and the plan doesn't work out. Right? We all learn the most when we fail or when there's a mistake. And so as they help each other sort through that, that's when the big learning happens from what I have observed of these experiences. And the other part, and I mentioned this before, the implicit learning that happens. So I'll just give you an example about how to position yourself in the room. Where should I stand when I'm working with a patient and I have a respiratory therapist next to me? Those kinds of things. So in this picture on the top, this is our speech pathology student, and you can see she's holding a chair, which is simulating a wheelchair. We didn't have a real wheelchair in the situation. But PT and OT are working with the patient. What do I do as a speech pathologist if I'm in the room? How do I make myself useful? And so some just learning on the fly of how can you do that? You could follow with the wheelchair so that the patient is safe and the PT and OT can do what they need. So as I said, it's not about the evaluation, but really seeing what the other disciplines do, how they do it, and really how your disciplines fit together and can build on one another. All right, so let's talk about the research. So over the last, I guess, 3 years that we've been doing this, we have gathered all different kinds of data. And as we talk about this with my student researchers, we have thought about lots of different things that we might try to measure from our students. So the first thing that we started with was self-efficacy. There are many tools for measuring self-efficacy related to IPE. The one we started with is the IPEC set. So it stands for the Interprofessional Education Collaborative Competency Self-Efficacy Tools. And I will no longer say that. I will just call it the IPEC set. It's a really long name. So this is the pre-post measure where they make some ratings on a rating scale of how confident they feel in these various skill areas: communication, teamwork, roles and responsibilities, those kinds of things. And then they complete that again after the experience. So I will show you some data on that measure. It's a pretty long questionnaire. That's a 40-question questionnaire. And as you might imagine, students don't always want to spend that much time making ratings. So we've switched recently to the ICAS that you can see up here, the Interprofessional Collaborative Competency Attainment Scale. It's a lot shorter, so only 20 questions, and they can kind of burn through it a lot faster. And the other thing about the ICAS, they do this whole thing at the end. So it's a post measure. So they reflect back to what they thought before the event, but they don't fill it out until the end. So just kind of note there's a room for bias in there, of course. Other things that we have thought about, so outside of self-efficacy, we are also interested in what are students learning and just what are their perspectives on the experience. So we've tried a variety of things, and I'll talk about what we found in each of these. Student reflections, asking them to talk about the experience, what went well, what were you struggling with, what did you take away, kinds of questions on those. Some short answers on a survey. So what do you think a physical therapist does? How does the physical therapist inform your clinical care? Those types of questions. And then the last category, we really want to know, I want to know, if an interprofessional education experience can help them learn more about a specific content area. So in the case of going down to UWL, can they learn more about stroke care in their own discipline just by doing that experience? As you might imagine, that's kind of a tricky thing to measure. So I'll share sort of where we are, but that is definitely a work in progress. So let's look at the data. Just keeping track of time here too. So I'm going to work backwards and talk about the most difficult measurement first, and then we'll get to the self-efficacy at the end. So for the stroke case that we've been working on, the students and I, not this year, but last year, came up with some knowledge-based questions. So things like, would you expect someone with aphasia, so a language problem, to have cognitive deficits? They should say false to that question. The challenge here is that they have to be very specific to the case that we're talking about, right? So there's not a published measure that we can use. We sort of have to create those based on what we know the case is going to entail. So here's what we did. Didn't do any statistics on this because we ended up with 7 questions and a pretty small, relatively speaking, number of students. So the striped bars are their pre-test scores on this true-false questionnaire, and then the solid bars are their post-test scores. My big takeaway looking at this, they have pretty strong knowledge before they even start. So everybody's over 70% before we even get into the experience. There's a little bit of improvement for a couple disciplines, but really not a lot of room to change. So this is one area we are continuing to think about how can we measure what students are learning in that specific content area. All right, talk a little bit more about student perceptions. And there's a lot here, so don't feel like you have to read the whole chart here. In this particular tool, we gave students some questions, listed a bunch of different roles that professionals might play when working with this population, and asked them to choose who would traditionally do that task. Is it a physical therapy job? Is it an occupational therapy job? Is it a speech pathologist job? Or they could check everybody. So any combination of those. So as we looked at that data, a couple of things sort of stood out. At pre-test, they sort of landed in these examples that are listed here. So they had a pretty good idea of the general obvious things that each discipline does. As we moved through the experience and had them re-answer this question at the post-test, the most interesting area is this shared areas at the bottom. So many of our students learned that all the disciplines can do some of these tasks. So if you think about like visual field testing, any discipline could do that. And I'm not sure they all realized that before they got into the experience and saw other disciplines do it. So I think that's the big takeaway here, is that students sometimes have a really narrow focus of who's allowed to do which kind of task clinically, and seeing other disciplines do that and do it well, maybe sometimes better than what they do in their own discipline, helps them let go of having to own that task or feeling like they have to be the one to do that. So I think that's powerful learning, harder to capture that piece of it as we look at that. All right, another way we looked at this, I mentioned the student reflections. So 1 year, we've done this more than 1 year, but we only coded 1 year. We did a qualitative content analysis of what we were seeing in those student reflections. This was Hannah and Brooke that did a pretty detailed and deep dive. So they found the general themes are kind of in the dark yellow at the top there. And what you may notice is that they kind of match with what's on the IPEC set. So communication is a category there, teams and teamwork is a category there, roles and responsibilities are there. So maybe not surprising that those would align pretty well, but it was neat to see that happen just organically. So I'll just kind of run through these briefly. Communication category, of course, there were lots of general statements about communication that just that they learned more about communication. But we did see some topics come up about advocacy, learning how to advocate for their own discipline. So it's easy to get in a team and have another discipline sort of take the lead. I always sort of tease our students that physical therapists sort of want to own everything. My husband is a physical therapist, so I have witnessed this a little bit, but they sort of feel like the leader always. So our students have learned a little bit about how to advocate for their own discipline and not just have to follow the lead of the PT. They also talked about how to give feedback to other disciplines. So it's not always easy to correct something that another discipline is doing. So they talked about that. And then being open to learning and hearing new ideas, thinking about new ways that they could maybe do some of the tasks that they need to do. In the teams and teamwork category, again, some really general statements just about being on a team. But some of the things that stood out a little bit more specifically, some of them talked about how helpful it was to have multiple hands in the room when they're seeing a patient, that they hadn't thought about that, how much it's difficult to just work on your own. They talked about how they balanced participation across the disciplines. So usually in that re-evaluation, after they debrief, they kind of rethink who's going to do what and how much time each person needs to spend with the patient. They talked about how they manage difficulties. It's not all just smooth sailing, as you might imagine. They run into obstacles and how they handled that in a respectful way. For roles and responsibilities, again, some just kind of general statements, but really diving deeper into what each discipline does with this population, this clinical population. Talking about the ease of the evaluation when you have the right expertise in the room. So, sometimes we're asked to make judgments about skills that a patient might have or not have. And it's not really our area of expertise, but if you bring everybody together, you can really have a more well-rounded and robust look at that. They also talked about learning where the boundaries are between disciplines. So what really is in my scope of practice and what's not in my scope of practice. Patient benefits was one of the things that we know happens as part of IPE already in literature, and it was great to see that come up in what the students talked about too. They could see how this would make a patient's life easier, reducing overall demands on the patient's time and the patient's energy as they were working through this. And then, as you might imagine, we had sort of this catch-all category at the end, just overall statements that they really liked the experience. Almost everybody was positive about it. Some observations that they made, but really kind of generic statements. So when we looked at it from a qualitative perspective, this is sort of how things shook out. And then we had one more way that we have looked at really their understanding of what each discipline does. So we had an open-ended question on one of the surveys, a pre and post-event survey, and we just asked them, what do you think this discipline does as part of their evaluation? How does that relate to what you're doing? So I have 3 of these that I will share. This first one is perceptions of the speech pathology field. The green is occupational therapy students, and the red is physical therapy students. And as we look at this, you can kind of see like effective communication and swallowing stayed pretty predominant through both. But it's pretty broad in that pretest, and there's a few things missing there that students didn't realize our field could contribute to. So we see some new things emerging as we move over there, some things that maybe they thought might fall under another discipline's purview and realized also fits well under speech pathology. So just another way of looking at that. We think about the perceptions of occupational therapy, the physical therapy and speech pathology students. So PT is red, speech pathology is blue. And in this category, we saw more of a narrowing, I would say, to more specific skills that OT implement. One of the things that's interesting, and this is just anecdotal things that students have said after the event, our speech pathology students have said that occupational therapy tends to kind of step back a little bit. I've heard that more than 1 year now. So I think it's a little bit of a just how this team evolves as they work together on that that particular case. But that may be a little bit of the explanation of why we see some of the shift with OT. All right, and then physical therapy, what do they think about what PT does? Again, green is occupational therapy, blue is speech language pathology. Kind of similar to the OT results, they were sort of all over the place at the get-go, kind of narrowed in on some of those skills like gait and balance and focus on lower extremities. I think one thing that comes out of this experience is the understanding that occupational therapy is sort of an upper body kind of discipline and physical therapy is lower body. That's a gross generalization. My husband would be upset with that description, but I think that's what the students sort of take away when they're in the room together. That may be how they divide and conquer some of their assessments. Okay, and then on to self-efficacy. And we've measured this every single time that we've been there. So I just popped up 2 of them here. The 2022 event over there was using the IPEC set. 2023, we used the ICAST, just to remind you that they're different tools, so the scales are different, and so you can't exactly equate them. But I think the big standout thing that we see, all the students have improved self-efficacy at the end of the event. Probably not surprising. I don't think that's terribly surprising. I would hope that they would walk on there feeling more confident in their ability to work with other disciplines. One of the things we were wondering as we went through this research is, does it differ by discipline? And it really doesn't. We see the same kind of trend across all the disciplines. So they're all gaining those self-efficacy skills. All right. So enough about students, right? Let's talk about the faculty piece too. And we haven't done any formal research here on faculty perspective, so that's probably a new direction that I need to start shifting into. But some thoughts from myself and from conversations with my collaborators at other universities, what we have talked about. The first thing is just this continual learning that happens even for the faculty. So as we go down to UW-La Crosse, I have observed the OT and PT faculty starting to know more about what we do in speech pathology. They've been practicing for years in clinical positions, but things that we have demonstrated, our students bring whiteboards or iPads, so you can kind of see that in our image here, to help with written communication, to support the patient, this type of patient. That's a very appropriate kind of tool to use. At this point, they just provide whiteboards now as part of the experience. They don't even have to think about it anymore. And that's the faculty learning something just from having our students be a part of it. I mentioned this a couple of times. I just think it's so important, the implicit learning that happens as students are there. I don't have to explain every single thing to them. They just experience it as part of that team, and then they can take that with them going forward. I think it sticks even better, how to position themselves, how to support other disciplines. So PT and OT, their students see our student use that whiteboard in communication, and 10 minutes later, you see the PT doing that with the patient too, which is pretty powerful to see. So just having them observe each other and be able to see how that can work. The peer model is pretty important as well. We can talk about how to do different kinds of assessments and how we would work with other disciplines, but really seeing someone who's at the same level, another graduate student who's still just learning, is a pretty powerful model for them to really develop some confidence as well. This next point, recognizing the student and program strengths, has been something that's been growing for me over the past couple of times that we've done this. The first time that we went, our students were a little apprehensive, weren't really sure what to experience. The most recent time we went in November down to UW-La Crosse. After the event, I had one student say to me something about, I felt so prepared for this. Our program is doing such a great job of making us ready to step into this kind of experience. I had whatever the opposite of imposter syndrome was. It's like, well, I don't know what that's called either, but good to know that you felt like you knew exactly what your role was and felt really comfortable stepping into this. So I think from a faculty perspective, it can be really helpful to just see we're achieving what we think we're achieving as our students go out and interact with students from other programs and other universities. And then the last piece, keeping things simple. So it can be really tempting to create this really complex scenario. I know I'm going to have multiple disciplines. Let's make it something really complicated. But I'm not sure that we need to do that. It's probably in our best interest actually to keep it simple, especially if it's the first time that they've ever worked with other disciplines. They need so much time just to talk to each other and strategize that we don't have to create some crazy case for them to take on. It can be a pretty straightforward, simple case, and then we can build from there. There's certainly prep work that's part of this process. So, if you're thinking about an IPE experience, you have to have something developed on the front end. What are you going to have the students do together? That can take some time. If you're in the sim lab, like we were with CVTC, there's some prep involved there to make sure that we have the sim lab staff on board. But I think it's worth it in the outcomes of what we see our students achieve. All right, so I'll just wrap it all up in a couple of quick points here. I think these events have been really successful at fostering student learning. The knowledge and skills related to the case, we're still working on how to measure that. I can see it, but I can't measure it yet, so I'm thinking more about that. Certainly learning about IPE and how to interact in a team and what other disciplines do. As I mentioned, this knowledge piece is something that's really difficult to measure, and we're still kind of thinking about that. I've been really pleased to see how all of these disciplines work together. They're at different points in their program, right? A respiratory therapy program is very short compared to our graduate students who are going through 2 full years. And it really doesn't matter where they are in their program, where they're going to school, they all interact very respectfully with one another, which is a positive thing. And then the simulation piece, specifically that hands-on learning with a case that's very tangible, has really facilitated student learning and helped improve their perceptions overall of that experience. All right, so references briefly, and then opportunity for questions for a couple minutes. Want to thank the Office of Research and Sponsored Programs. They've supported various components of this line of research, and the CSD department as well for various components of that. So thank you. Yeah, so I'll repeat the question. Who role plays the patient when we're at UWL? And then what do they gain from it? How is that different than the rest of the students? So yes, it's a student in one of those programs. So we put them in groups of usually 5 or 6. So they have at least one from each discipline. Usually there's 2 PTs. I don't know why the PT program is huge in comparison to ours, but it is. So usually it's a PT student that ends up in that role. They get some instructions. And I think the learning there is also really important. So trying to figure out, how do I play this role? What would this type of patient look like? It's a different kind of learning. So you're not on the clinician side, but you're thinking from a patient perspective, what kinds of challenges they would have. So there is pretty significant learning that happens there. We have them rotate, so they don't play the patient for both iterations of their evaluation. So a different person gets to do that. I will share that it's really interesting to see our CSD students play the role of the patient. I think they do a much better job. The PT students don't fully understand the communication challenges that a stroke patient might have. And so they sometimes don't role play that very well. The physical part is easier to see, so our students can sort of manage that, but they have this deeper understanding of the communication components. So it's kind of interesting to see how much more richness there is when our students play the patient, but lots of learning in both roles.
Abby, I really enjoyed this talk and learned a lot. And I'm also curious about how typical IPE is in speech language pathology programs.
Yeah, it's growing significantly. It has been added as a component that we need to start incorporating. So we have standards set by our national organization. We are an accredited program, and so we need to meet those. So it's a component of that. Everybody recognizes that that's a big part of what we do, not just in healthcare. I'm talking about healthcare here, but in educational settings, we are part of the special education team often. And so everything we do is in collaboration with others. So it's happening a lot more. I think most programs are still sorting out, how do we make this happen? Because we need other people to be willing to play with us, right? To come in and participate and collaborate to make it happen. So it's growing, I think, slowly but surely over time. Some of it we've been doing here for years, though. The Human Development Center has been around for a very long time. Yeah. So the question is about conflict within the team, or whether we would want to stage any of that for our students to learn from. It does come up sometimes, and not necessarily anything that I would say is a huge issue, but some just differences of opinion about how they might proceed. And they sort of organically just work through that, which I think is good. We have thought about whether we might do that. I think some courses like ethics courses where students are together might get closer to those kinds of conflict management and conflict resolution options. I haven't figured out yet how to build that in. So when we look at the IPEC set, ethics is the other category. So roles and responsibilities, teamwork and communication, all of that just happens in the event that we have, but we don't have a big ethics component. I think if it was a controversial ethics kind of issue in the case, we might get more of that. So I think we could create it. It'd just be some pre-planning for that. Yeah, can I summarize that question in one sentence? So
No.
how can you continue this and grow it and use the repeatability piece to help student learning, right?
Yeah, and when is that not valuable?
Yes, yes. So I don't know that we know the answer about where is the point where it's not valuable anymore. Our students, the students who just did this experience in November are out on externship right now. So they need a couple of repetitions before they get there. Once they're out there, they're seeing it every day. So, you know, I don't think we have to necessarily get to saturation. Multiple repetitions would definitely help solidify their learning. I think, you know, that chance to have some reflection and then an opportunity to do something with what they reflected on is pretty important. So far, we haven't done a ton of that. So the CVTC experience now is in the spring, and then the UW-La Crosse experience is in the fall, and then they go out on their externship. So we've got a little bit of a sequential build. My colleague's experience is in the spring that he does with nursing. So we're starting to get a little bit of momentum, but I think we need to work on that and think about how that fits into our curriculum, because it will take some time away from other things. You know, then we have to think about the learning outcomes. What can we just embed right into the experience as opposed to needing to address in a classroom setting? So some work to be done for sure. We are at 12:50. I'm watching the clock too. I don't know if that's your job, but yeah,
Great.
good enough.
Well, thank you.
Thank you.